So I guess we're going to continue pretty much the same discussion. It's going to be controversies in structural heart, and here I'm accompanied by Dr. Abdulrahman Almoghairi, Dr. Amani Al-Subari, Dr. Hamid, Dr. Abdullah Asiri, and we have four eminent speakers. The first speaker will be talking about, it's actually a case-based discussion. Dr. Abdulrahman Almoghairi, he's the Director of Research Department at Prince Sultan Cardiac Center and the Director of General Cardiology Training Program, the Director of Adult Interventional Cardiology, and the Head of Cath Lab, who present us a case on asymptomatic severe aortic stenosis. That will be followed by panel discussion and if any questions from audience, and then after that, a few slides on the evidence to back up their decision.
Bismillahirrahmanirrahim. So we'll start with the case. The case is an elderly patient with a history of pacemaker implantation for the complete heart block. And also he had a history of paroxysmal atrial fibrillation on the anticoagulation with history of brain hemorrhage. Then for this he underwent the Watchman device to minimize the anticoagulation and to reduce the risk of emboli. The blood sugar is controlled, hypertension is controlled. He has a dyslipidemia. He is a retired general, and he's an athlete. He's very active. His ejection fraction is normal. The coronary is non-obstructive, and he has no symptoms. He incidentally detected to have the severe aortic stenosis, and he denied symptoms at his daily activity for his age. The routine clinic visit detected this, as I mentioned, and also he was seen initially at the local clinic and referred for the further evaluation of the valve for his. When we discussed with him the options, whether to continue on medical therapy, and he supported us to go for the replacing the valve. This is the echo. As you see, the valve is severely calcified, severely stenotic, with the gradient is high, and LV function is normal. He has some mitral regurgitation. But we know from the literature that the functional mitral regurg improves in 50% of cases after relieving the afterload. We proceed with the evaluation with the CT and planning and taking the measurements. As we see, it's favorable for the transcatheter therapy. So, and as we see, there is nothing specific for this case, not different from the other patients, similar evaluation. Then we went for the valve. And the rationale for the early intervention is to reduce the myocardial damage, because the aortic stenosis is a myocardium. And because the chronic afterload, so it may end up with the LV dysfunction. Also to reduce the mortality by improving the obstruction, reducing the risk of sudden death. This is just our justification to go for the procedure. And similarly for the surgery, if you have a young patient and you wanted to send him for surgery, probably the justifications for the intervention goes through this same discussion. And the guidelines, and even before the early trial, which supported the FDA approval for the implanting a valve in an asymptomatic patient, it was not in the class 1, maybe class 2B at that time. And this is his which is documented in the guidelines for asymptomatic patient. Either the ejection fraction start to come down, or the elevated BMP to suggest early heart failure, or abnormal exercise test. Elderly patients, we cannot exercise them to assess the, or severe calcification by echo to support, by CT, I mean, with the rapid progression. Then we went for, as you see, the watchman is in place, and we went for the valve implantation. We followed the usual process. As you see, the patient has a pacemaker, so there is no concern about the risk of pacemaker in the future. He's already have it. And the valve is deployed. We went with the new generation valve, which is the latest as of now, because there is a coming generations more to also to look for the calcium for maybe durability in young patients if we use it in the young patient. This is a Resilia valve, and the result is reasonable. And this is the echo in position. There is some sort of LVH. And the current evidence is maybe in favor before the early now is adding it to the FDA for justifications to add it in the IFU for the current valves. And the benefit and concerns of the TAVR in this group of patients who has no symptoms, it is minimally invasive, prevents the LV dysfunction, prevents sudden death. But the concern if you have complications like the stroke or the valvular leak or pacemaker, and those who have no pacemaker, and the long-term durability also is a concern of young generation. And the patient selection, as we mentioned, based on the constellation, either symptoms, clinical risk factors, and also the findings from the imaging. And in conclusion, the TAVR for severe asymptomatic aortic stenosis is maybe promising before the added to the guidelines. Yes, it needs more evidence, and yes, the result of the early trial now came and also supported adding it to the FDA approval, and the risk, the stratification remains the key. And I will leave the discussion for the colleagues to discuss this evidence.
Thank you, Dr. Abdulrahman. Really good. So I think we're going to have like 2 or 3 minutes of discussion, and maybe you can start with Amani. I mean, this is critical AS, no doubt. I mean, you can see that the valve is not moving, but the patient is asymptomatic, and he's a high-risk profile patient. He's elderly, has comorbidities, etc. Would you do exactly like what Dr. Abdulrahman does?
Absolutely. After I heard the discussion in the last session, it was really a great discussion. I don't think a lot of you will agree with me, but I think we've been sleeping on the fact that severe aortic stenosis is the most likely risk for stroke. And we have now like 4 major trials, which is RCT trials for asymptomatic patients, early TAVR, Avatar, Recovery, and Evolved, that's showing the benefit of decreasing the stroke and reducing the heart failure hospitalization. So I think that should be enough to drive the needle to changing the guideline to put an AVR or TAVR in asymptomatic aortic stenosis as a class 1 indication.
Sure. I mean, most of these trials are really small. I mean, maybe with the exception of early TAVR.
We know that,
like almost 1,000 patients.
Yeah.
And most of the primary outcome, actually, the primary endpoint was driven by unplanned hospitalization, and not because of acute issues, symptoms progression.
Yeah,
So
I still believe that.
Do you think it's reasonable? Like, do you think that patients, knowing who has a structural heart disease, that will be really anxious and maybe hypervigilant to report symptoms, even minimal symptoms?
I believe in Barton trial, there's in sub-analysis group, there is a 40% in 2 years, 3 years after diagnosis with asymptomatic severe aortic stenosis will come back with acute valve syndrome. So for me, early TAVR in those kind of patients, that means early planning, early organizing care for the patient instead of doing the TAVI when patient presented with acute symptoms in chaotic way.
Abdulrahman, anything to add?
Yeah, just want to add one practical point from my experience in my patients. Most of the elderly who comes with severe aortic stenosis, and they deny symptoms and most of the time because of the fear of surgery. We've seen this in our communities and in our patients here in the Gulf. And the clue usually is when you inquire about their limitation and their activity. You'll find that they creep down on their activities. And if you ask him, for example, what was the activity he was doing about before 2 years or 3 years, he will tell you that there is definitely reduced. For example, he was not able to walk to the mosque, and he started praying at the, at the home. So they, without, subconsciously, without telling that they have a symptom of chest pain or short circuit. So this is something you have to pay attention to.
Okay.
I think personally, talking about asymptomatic debate, I think we overdiagnose asymptomatic ACS, aortic stenosis, because I think if what we usually do in practice, if a patient claims that he's absolutely asymptomatic, okay, we just take him for a quick spin. It's just like, few minutes walk. If they can't do it, then they might be truly asymptomatic, then we send them for a stress test. One of the issues that we see, the discussion would be easy if you send the patient for surgery because they will decline, and that's one of the reasons to undermine symptoms. But with TAVI, it's, most of the patients we don't find difficulty convincing them if they're, truly have some symptoms. But if they are quite adamant they're asymptomatic, then you truly need to do further testing for them. And I think we, underutilize the stress testing.
Sure. So I agree. Most of these trials, if in early TAVR, they did not look for, or they didn't screen for cardiac damages. They did actually stress test to tell if they're truly asymptomatic or not. Abdullah, the only maybe trial was a small one. The evolved TAVR, they actually checked on the MRI, CMR, mid-wall, late gadolinium enhancement, and it was actually positive there. But the trial was not positive. The trial, it was neutral. It was a small trial though. So what do you think, Abdullah? Do you think we should do more testing before we decide on when to TAVI or not TAVI for asymptomatic?
Like this patient, he proved himself to go for TAVI. Elderly patient with a lot of comorbidity. He already have stroke with bleeding. He have complete heart block, AF patient. So assume that the functional capacity will not be that great. So like this patient is straightforward to go for TAVI or to think about TAVI at least. In asymptomatic, other asymptomatic patient, we are looking to the guideline. They are talking about the ejection fraction, the amount of the calcium, the severity of the valve. Maybe if involved the imaging in future, it will be as a great additive point to decide which to go for TAVI.
Thank you so much. I think also, if you take it from cardiac damage, maybe even the moderate AS, they have cardiac damage. So I think, thank you, Dr. Abdulrahman, and I think